This is the case of a 53-year-old female with a medical history of morbid obesity, BMI 40. On February, she underwent a sleeve gastrectomy followed by staple line leak and sepsis. A fully covered self-expandable metal stent was placed, beta stents, as you can see, with a complete healing of the fistula. The dimensions are 24 millimeter in diameter and 20 centimeter long. Current problem. The patient has been admitted for self-expandable metal stents removal. Scheduled procedure. Fully covered self-expandable metal stents removal. Learning objectives. Discuss the endoscopic options to manage bariatric surgery complications. Let's go to endoscopic room.
So, good afternoon. I have the pleasure to work with my friend Ivo Borkowski. And we will start this procedure. So this patient had a leak after sleeve gastrectomy. You know that stents is probably one of the first options, especially when the patient has a collection which is drained. Another option that has to be kept in mind if the leak occurs a little bit later is to drain this collection like you would drain a post-operative collection with double pigtail stent. One of the things with this beta stent is that there are some anti-migration properties, but if you compare the image that we have now and the image that you have seen on the case presentation, you see that there was indeed a migration of the stent, which has migrated up to the cardia almost, and which is now forming an angle with the esophagus, with an impaction at the level of the esophagus. So these stents are quite effective, but if you choose to use these stents, you must be sure that the patient will be reconvened after 1 month, like it was for this patient, and not to leave the stent more than 4 weeks after the healing of the fistula, because otherwise you have a risk of perforation, especially at the level of the upper part of the stent. Again, you see where this stent is forming an angle with the esophagus. On the other side of the stent, you see that we also have some impaction because the stent migrated up to the angle of the sleeve gastrectomy. And this is always the position in which you find these stents. But when you decide to use fully covered stent, this is maybe a good choice. You know that another possibility is to use partially covered stent like the Ultraflex and then to remove it through the placement of a fully covered stent for a few days inside in order to induce an ischemia of the hyperplasia. So here I have a rat tooth forceps, and I will try to catch the upper part of the stent, something which may be a little bit difficult because of the size and the impaction. Open. And then Ivo is opening the forceps. I will see on fluoroscopy if I catch it close. And then we will see if we have it. Yes. It's a little bit a blind catch. It should be there. It seems to move. And then I will see if we got it in a good position. You see that when I will try to remove this stent, I will apply a traction, but I will not increase my traction. I will just apply a continuous traction of the stent. I want to dislodge it from the cardia, and then you have to take your time. It may take a few minutes before the stent will follow the endoscope. You see my traction is a continuous traction. But you see that of course the diameter of this stent, even if it's relatively atraumatic, the diameter of this stent can be an issue. But one of the tricks, again, is that you apply a traction but you do not increase your traction. You just maintain the traction as the same force all over the removal, all over the stent, and then you see that we have this big carrot, which is quite impressive in size. So now we will have a look with the endoscope. Thank you. We have enough for the breakfast, Thibaut? Okay. And then I will go back in. We will see which is the result, and especially check the area of the cardia. You see that this is what I explained. And again, if you use this stent, don't leave them in place more than 1 month. When you use a partially covered, you can leave them for 2 months. You see that there is some relatively deep ulceration. In this case, it's not a clinical complication, but this is something which suggests that we should be careful. And again, I will go a little bit deeper. You see that as usually in a sleeve gastrectomy, we have an angle between the antrum and the corpus of the stomach. And this is the bulging that we were seeing. And you see that this bulging is corresponding with a deep ulcer. This deep ulcer is the one which was induced by the impaction of the stent when the stent migrated. So any fully covered stent which is placed in the GI tract will migrate, and especially in sleeve gastrectomy, it will always impact itself at this level, which is the angle between the antrum and the body of the stomach. So now we can make a control with the fluoroscopy. Can you adjust it? Okay, thanks. Thank you very much. And then you see that we have, of course, no leak, so that's the good news. So this is impressive, but in this case, without any clinical complication. We will just give some PPI to the patient, and as usual also, if you can come back to the cardia. Okay? As usual, the leak is usually taking place at the level of the cardia, so I will repeat an injection there, just to be sure that the leak is completely closed, but clinically the patient has no more symptom and no more fistula. And again, I'm pulling back very gently. We are just at the level of the cardia now. I will again inject a little bit of contrast to check that our treatment is satisfactory, and to be sure also that we have no leak at the upper part of the stomach, which is, no, it's okay, which is the area of proximal impaction of the stent. So again, now I will suck the contrast for my friend anesthesiologist, because they don't like to have a lot of contrast when they will wake up the patient. I always do this procedure with the patient intubated, especially with this large stent, because you can be in trouble if you lose the stent when passing the upper esophageal sphincter. So I think that the patient is intubated is another safety for this kind of procedure. And in this case, this patient is treated.